Hello, everybody. I appreciate you attending our webinar today. Tria Health is hosting a webinar with the title Diabetes, Drugs, and Weight Loss, What's the Skinny? My name is Jessica Lee, and I am the CEO of Tria Health. A pharmacist by training, I've been involved with the development of Tria, which is a chronic condition management focused on utilizing the expertise of pharmacists to help members who have chronic conditions improve their health outcomes. We're excited to have you all here today. Just a few housekeeping items. Hopefully, everyone should be on mute. And for the remainder of the webinar, we'll have everybody on mute. Please use the chat function for questions. We've had a few questions submitted, but please submit any questions you may want to share throughout the course of this webinar. It is my honor and pleasure to have a colleague of mine here with me today, Austin Morgan. Austin is a very talented and educated pharmacist who knows a lot about this topic. So I'm going to pass the baton to him so he can share all of his expertise regarding this very interesting class of medications that we're hearing a lot about. Austin?
Yeah, thanks, Jessica. That's very kind of you to say. Welcome, everybody. I'm happy to be talking with all of you, and I appreciate you taking time out of your day to learn about this interesting topic. Just to orient you to me real quick, I'm a pharmacist by training as well. I currently serve in the role of lead clinical pharmacist overseeing development and training here at Tria Health. I've been with the company for a little bit over 4 years after completing my postgraduate residency training. And I currently am a board certified ambulatory care pharmacist and certified diabetes care and education specialist. And spend most of my time day to day, week to week, working with patients with chronic health conditions, including diabetes, overweight, and obesity. So as Jessica mentioned, this is a topic very near and dear to my heart, and I'm excited to talk a little bit more with all of you about it today. So want to start a little bit by orienting us to the medications that we're going to be talking about. So weight loss, especially at the start of the year, is often at the top of many of our minds. We're making New Year's resolutions to make lifestyle changes, start exercising more, maybe changing how we eat. But one thing that was a little bit different for many people in 2023 around the new year was likely considering a little bit about what role might medications have when it comes to helping me with this weight loss process. So to start by talking a little bit about the meds that we're going to review in more detail today, the class is called the incretin mimetics, and they've been around for a while. The first drug in this class was discovered and created in about 2005 under the name exenatide or Byetta. Fun pharmacy trivia Jeopardy fact for everyone, it was actually discovered from the saliva of the lizard, the Gila monster. And it mimics a hormone our bodies naturally produce, and it was found to be effective at lowering blood sugar. So it led to an approval and marketing to be used for diabetes management under the brand name Byetta. Now, over the years, like with many new drug classes, newer, longer lasting, more potent medications were approved in this class. Some examples many of you are probably familiar with here include drugs like Ozempic or Trulicity. And they last a long time. They're injected just once a week, and they're very effective at lowering blood sugar. We did have a new member into this drug class just last year. I'd call it a kind of a cousin medication because it not only targets the GLP-1 receptor, like drugs like Ozempic and Trulicity, but it also targets GIP, so another incretin hormone our body naturally produces, and that drug's Mounjaro or tirzepatide. So we'll talk a little bit more about these medications later on in this discussion. Along with lowering blood sugar and A1C in the diabetes trials that led to these drugs being approved for diabetes management, trial investigators found that the medications also helped with weight loss in many cases. So we'll describe the weight loss trials a little bit later, but this led to further evaluation and then FDA approval for some of the medications in this class for weight loss as well as type 2 diabetes. So while the medications have been on the market for quite some time, 2005 and the newer agents for a number of years, you can see in this Google trend chart from the last 12 months that in the last 6 months or so, there has been exploding public interest in search for drugs like Ozempic and Wegovy and these other medications in this class. And there's really a good reason for the public's significant interest in these medications, and that's that in a lot of cases they do work. So clinical trials for the product Wegovy which is semaglutide. And we're going to spend a little bit of time getting into the semantics of these medications, but semaglutide is the same active ingredient as Ozempic, but Wegovy is the version that's approved for obesity and weight management. In those clinical trials for Wegovy, people using the active product lost between 10 and 17.5% of their body weight on average. And it's important to note that this was on top of lifestyle and diet and exercise changes. So compared to placebo, these people using this medication lost between 10 and 17.5% additional body weight, whereas the placebo comparator group lost up to 5% of their body weight, and even in some cases gained some weight over the course of the intervention, which was typically about a year. And then in the other diabetes trials for drugs like Trulicity or Byetta, things like that, there was weight loss. It was typically somewhere in the range of 5 to 15 pounds. So not quite as robust as a drug like Wegovy, but certainly helpful from a diabetes management perspective. A lot of times we are weighing using medications that could even cause weight gain. Insulin causes weight gain. Some of our older diabetes medications often cause weight gain, which creates this kind of hamster wheel effect of challenges when it comes to managing some of the comorbidities with diabetes. So those effects are beneficial, but not as robust as some of the newer agents. And then I do want to point out that Mounjaro, which is currently, as of right now, only FDA approved for diabetes, it does have a pending accelerated, expedited application into the FDA for a weight loss indication. But in its clinical trials for weight loss so far, patients are losing between 15 and 20% of body weight, with many losing more than 20% of their body weight compared to placebo. And these results from both Wegovy and Mounjaro in the clinical trials are really unprecedented. We have other medications on the market for weight loss with that FDA approval, but we've never seen any medications that can contribute to 15, 20+% weight loss like these drugs do. The only sort of intervention that's really available to these patients who need this much weight loss is bariatric surgery. So things like gastric sleeves, gastric bypass, which is obviously very invasive and a big decision to move forward with that. So with the results of these meds so far, we're really breaking into an uncharted territory with how much benefit we can possibly see. I want to touch a little bit on the similarities and differences, because like we mentioned briefly there before, some of these drugs have the same active ingredient. So it gets a little bit tricky to flesh out what's different between them. So want to draw specific attention to semaglutide, which is the active ingredient in both Ozempic, which is FDA approved for diabetes management, and Wegovy, which is FDA approved for obesity and weight management. And then the other drug in this class that shares multiple approvals for both diabetes and overweight and obesity is liraglutide, which is an older version. It's once daily, so we don't see it used as often, but the brand names for that are Victoza for diabetes or Saxenda for overweight, obesity, and weight management. And these medications have the same active ingredient. It's the same mechanism of action. They're doing the same thing in the body. Really, the only difference to us in clinical practice is how the drugs are dosed, and then how they were studied in clinical trials and provided the evidence for us to use them in practice. So the versions that are FDA approved for weight management and overweight and obesity specifically evaluated losing weight and the amount of weight in people both with and without diabetes, which is a key difference compared to the products that were approved for diabetes. So Ozempic, Mounjaro, Trulicity, those drugs, when they were studied and approved for diabetes, were looking at a drop in A1C, an improvement in blood sugar, an amount of time that patients spent in a goal blood sugar range. And then the weight loss was more of a secondary outcome that was a fortunate happenstance finding that then led to these additional weight loss trials. So while the drugs were studied for diabetes, the dosing was different, specifically with semaglutide. So when Ozempic was FDA approved for diabetes, it was dosed up to a once weekly dose of 1 milligram once per week. When Wegovy was studied and FDA approved, it was dosed up to 2.4 milligrams once per week. And in the evidence, we can clearly see a difference in the amount of weight that people lose at those higher doses. The thing that makes this even more challenging right now is that there have been more studies conducted looking at Ozempic at higher doses. So to see if higher dose of semaglutide will actually lower blood sugar more. And it does. So now the highest dose of Ozempic is actually 2 milligrams once per week. So you can see that the difference there is 2 milligrams once a week of Ozempic for diabetes, 2.4 milligrams once a week for Wegovy for obesity and weight management. And in clinical practice, there's not as much of a line as there used to be. I keep giving these one-offs about Mounjaro, but it is a little bit different. So in the clinical trials is actually dosed the same, both for diabetes management and overweight and obesity, but it does have a slightly different mechanism of action compared to the other drugs in this class. It targets both that GLP-1 receptor and GIP. And we really don't know for sure why hitting that second mechanism allows it to be more effective for weight management and in terms of lowering A1C. It might have something to do with better insulin sensitivity response or possibly further appetite suppression, but we're going to have to wait and see as more post-clinical trial data comes out and more evaluation there. And really these differences in the FDA approvals that I touched on earlier and the different drug products leads to probably the biggest difference in actual day-to-day life, which is a difference in insurance coverage. So the products that are FDA approved for diabetes, Ozempic, Mounjaro, Trulicity, are normally available to people with diabetes at their branded copay tier, tier 2, tier 3, depending on formulary preferences and contracts. And this is completely appropriate for managing diabetes. These medications are basically recommended 1B in the American Diabetes Association and the American Association of Clinical Endocrinology practice guidelines. We have a host of evidence on the value that they bring. Across the board, we normally see A1C drops of up to or over 2%. These medications improve other metabolic markers, things like weight, cholesterol, blood pressure. They lower the risk of heart disease in people at very high risk for heart disease who also have diabetes. And then with those benefits, it can sometimes allow us to stop other medications for these conditions. I wanted to call out a couple of real world examples that I've had here even just in the past 2 weeks. So I've had 3 patients in the last 2 weeks who started on Ozempic or Mounjaro respectively for diabetes management. So it was within those labeled indications. All 3 of them over the course of 6 months between follow-ups had A1C drops down to less than 6.5% from between 7.5% and 9% at baseline. 2 of them have lost over 20% of their body weight, and 1 has lost over 10% of his body weight. They've been able to decrease insulin doses or stop other medications for diabetes and blood pressure. The patient using insulin has had fewer low blood sugar episodes because they needed less insulin. These medications don't normally cause low blood sugar on their own. And then they all expressed improved quality of life. They're feeling better, they're moving better. And one of the patients, I like this quote and wanted to share it, said, "This medication is absolutely fantastic." So in the right setting, when someone responds well and when used appropriately, these medications can make a really big impact on people with diabetes. Now, on the flip side, from the weight management perspective, a lot of plans are not covering the drugs that are FDA approved for weight management and obesity for that indication alone. And this is not uncommon. Like I said, we have other drugs approved for weight management, and those medications are often excluded from coverage. And when we don't have any insurance coverage for drugs like Wegovy or Saxenda, these medications are basically inaccessible to patients. The out-of-pocket cost is between $1,000 and $1,600, depending on where you look for that information. And even with the manufacturer savings programs that are available from the websites, which can reduce the cost by about $500 if not covered by insurance, we're still talking about $1,000 a month, which for most people is really still inaccessible. So because of this situation in real life, and because of the similarities between the products approved for diabetes and obesity, many patients and prescribers are using those diabetes medications off-label for people without diabetes to help them lose weight. So using a drug like Mounjaro, which is currently not approved for obesity or weight management, using a drug like Ozempic, which is not approved because they've been available at those branded copay tiers for people with diabetes. And in clinically, this is rational, right? The meds work the same. They're dosed very similarly. There's no real difference in tolerability that we see between the trial data for people with diabetes versus those without who fall into the overweight and obesity category. But where it does lead to a lot of challenges, which I think is why many of you are here today, is to talk about what do we do about cost management? How do we design plans and integrate appropriate utilization strategies, which Jessica is going to talk a little bit more about later on here. And now that we've talked some about the medications themselves, I want to highlight a little bit of information on what the increased media attention on these medications has done. So along with that Google Trend data, where we can see, people are searching for these medications more often, both social and mainstream media are talking about these medications in a lot of different ways. And like many things in the media, there are basically two sides to the coin. The increased attention has raised awareness that overweight and obesity are chronic health conditions. There's situations where, despite lifestyle changes, people with overweight and obesity may need something else, including medication, to help them achieve those weight loss goals. And while there's still plenty of research that needs to be done in the overweight and obesity arena, long-term outcomes, trying to separate out the impact that overweight and obesity have, absent other comorbid problems like high blood pressure, cholesterol, on things like heart disease. Most experts in the field and data do agree that there are underlying pathophysiologic changes and problems that exist in people with overweight and obesity that may require more intervention than just lifestyle alone. And to draw some parallels, we have a lot of health conditions that can improve with lifestyle change, things like blood pressure, cholesterol, diabetes, acid reflux, arthritis, a lot of things that can improve. But if people are not able to fully invest in those and carry out those changes, or maybe there's just something going on where those changes alone are not effective enough, we still use medications to treat those conditions to ultimately lower the long-term effects and improve the quality of life associated with them. So with this increased awareness and people knowing that there are effective, useful treatment options out there, there are likely going to be many folks who get medications that will help them lose weight and improve those long-term outcomes that they may not have otherwise even known were available to them. Now, on the other hand, this increased awareness and increased utilization, particularly of the off-label drugs like Ozempic and Mounjaro, has created massive problems when it comes to diabetes management with these drugs. So the huge surge in uptake off-label has led to shortages in the medication. The manufacturers are having backorder problems, are not able to keep up with demand. And this leads to treatment delays. We've had so many people we've talked to here, and you could go and talk to many pharmacists, many doctors in your community, and I would almost guarantee that they're going to all say, yeah, we cannot keep these drugs in stock. People who need them for diabetes cannot get a hold of them. And this leads to problems clinically. Diabetes control goes down, A1Cs go up, patients lose their routine and are no longer as adherent to their medications. If they're having to shop around to different pharmacies, I normally go to pharmacy X for all my medicines. They can't get my Ozempic, so I'm going to go to pharmacy Y. Pharmacy Y doesn't have any background on that patient. They can't check to make sure that any future refills of that medication that they're filling aren't going to cause problems with the other meds. So we can run into some polypharmacy issues. And then kind of worst case scenario for someone with diabetes and these medications is they have a long gap, a month or longer, and they have to restart the whole treatment process. These meds come with side effects, and one way we help manage those side effects is start at a very low dose and gradually titrate every 4 weeks to the target dose as it's tolerated. If we go a month or longer without medication, it's basically out of the body, and we can't start back over at that same dose. We might have to start all the way over at step 1. To get to that full dose of Ozempic, it's 5 steps. So now we're talking about 5 months of treatment delay to be able to get back to where we were going to try to get that A1C reduction. So while the increased media attention and awareness has definitely helped people when it comes to overweight and obesity management, it has definitely hindered and hurt some people who are using these medications to help manage diabetes. And then to wrap up the clinical practice side of this, there are many benefits to using these meds. They're very effective to treat a chronic health condition. Overweight and obesity for a long time has been seen as possibly a moral failure, or you're not doing enough, or you need to eat better and work out more. But we know that there's more to it than that, and these medications can help. They can help improve outcomes with other health conditions, high blood pressure, cholesterol, lower the risk of heart disease. It can improve blood sugar profiles for people who might have prediabetes and are trending toward diabetes, possibly even preventing that from ever happening. And they're easy to use and overall pretty well tolerated. But on the flip side, there are challenges to patients and plans that are very real and we need to be aware of. These drugs are costly and they require oversight to use them right. And that could be prior authorizations, could create formulary restrictions, which can make access difficult for patients and providers. There are also concerns over people using these in that vanity space, which is, don't have overweight, don't have obesity, and we weren't looking at the effects of these medications in those people. And clinically, there's probably not much rationale for using medications to help people who don't have overweight or obesity. It can worsen body dysphoria. It can ingrain problems with self-image and mental health. And there's a lot of concerns that these medications may reinforce issues like eating disorders. And then for effectiveness, not everyone responds to treatment. I gave a few examples of people who responded really well, but in clinical trials, not everyone does. Those numbers presented earlier are averages, and they're impressive averages, but there's a flip side to the big responses. Some people don't get much benefit. And then they do have side effects. Most people will experience some GI upset, nausea, vomiting. That's normally overcome with time and with some counseling, but it can cause more severe side effects, things like pancreatitis or gallstones. We did have an incident here in the last few months where a TRIA pharmacist was doing a follow-up with a patient. That patient told them that they were recently hospitalized. They were having stomach issues, gallstones, and inflammation of their pancreas. The patient was using a GLP-1 agonist. In this case, it was actually Ozempic. And the pharmacist recognized, like, hey, there's a connection here. That medication may be contributing. And they actually worked with the patient and the physician to get them switched off of that class of medicine, get started on something else. Fortunately, we were able to help them find another effective med, and that patient's A1C remains at goal and they haven't had future problems. But it does highlight the fact that there are some serious issues that can happen. And when we put these medications out in a broad way to many more people, there are risks that we may run into. And then there's the concern about long-term use. We do have clinical trial data that shows that people who stop the medications often will regain weight. And it takes significant lifestyle change with diet and exercise and education in order to sustain these benefits without needing the medication long-term. So it creates a lot of challenges. And with some of that background and foundation on the clinical side, I'll go ahead and hand this back over to Jessica to talk a little bit more about some strategies to consider when it comes to benefit coverage and long-term access.
Great, Austin, you brought up a lot of really important points, and I'm seeing a lot of questions on the chat. So hopefully this next section will help to start giving some of those answers to some individuals. I think if you want to go ahead and switch to the next slide, Austin, we'll talk a little bit about what we're seeing in the benefit plan sort of coverage arena. Obesity getting a designation as a disease several years ago put sort of in light sort of the challenges for self-insured employers on how to cover weight management. And it's probably in the 50 to 60% range where we're seeing plan sponsors covering these medications, but many times obesity medications or medications for weight loss are being covered in some way that sort of either ties it to a program and or sort of puts limits in place and or steps in place or hoops in place with prior authorization to ensure plan protection. Obviously, Austin alluded to the fact that this category of drugs is uniquely different than any of the obesity drugs we've had previously, mostly because of the challenge related to tolerability of previous drugs and sort of limitations around certain patients who couldn't be on those drugs. But I think also what we're seeing is that if you look at the sort of categorical nature of people who would be eligible for this drug, if you let this drug be free for anybody and they could have it, we'd be seeing over 50% of the population utilizing it. So that's really something that we need to think about in terms of protecting your plan as a self-insured employer. As we look at the rise of GLP-1s being used off-label as well, we're also sort of wanting to ensure that the right people are getting the right medication. And so what we're seeing is more and more plan sponsors considering putting in place prior authorization around this category of drugs in the incretin mimetic category. That prior authorization across the board in all of those drugs allows for assurance that the medication is being used for the right person. For example, with those that are FDA labeled for diabetes, you ensure that that individual has an ICD-10 code related to diabetes and/or they've had diabetes medication use in the past, which allows the certainty that that medication is being used for that purpose. If a plan decides to put coverage in place for medications around obesity, that is when you want to start thinking about maybe putting in another prior authorization around those drugs that are also just FDA labeled for obesity. Some of the things that we're seeing that I think are still important in terms of limiting the plan's exposure and also allowing access to the right person is to ensure that you're meeting the criteria of obesity. So by putting a prior authorization in place for things like Wegovy, you require that the individual meets the criteria of having obesity BMI. Now, let me rest assured that I'm sure we could have an entire webinar that discusses whether BMI is truly the right measure of obesity. But right now, when we look at the way the studies were done, as it relates to obesity, we know they define obesity as a BMI of greater than 30. Now, another category of individuals that would be eligible to receive these types of medications would be those individuals with a BMI of 27 to 29 who already have a comorbidity that we're referencing here that are one of the many 40 plus comorbidities and disease states that we know are secondary to obesity. Those groups of people that meet that criteria, along with being actively involved in some type of a weight management program, is key to ensuring sort of the right protection around the medications. We believe strongly, both our clinicians and then our philosophy here at TRIA believe strongly that it's really important and critical that you do sort of a behavior assessment and an understanding of that willingness to change the behavior alongside the use of the medications as a kickstart. And then long-term side-by-side coaching and handholding with those individuals as they work towards understanding the changes that are necessary to achieve the lifestyle changes once the medications are no longer wanted or needed. I think Austin alluded that some of these studies are going long-term, so we're seeing the use of these medications. They're studying the use of these medications long-term. However, in order to sort of put the plan in the best protected light, we usually recommend that our partners who are utilizing our weight loss management services alongside their benefit plan design to also put a limited time approval in. Generally speaking, with most of these weight management medications, and particularly with these GLP-1s, you should be able to see some response within 6 months. So response is a conversation, tolerability, and then 6 months is a good amount of time to also establish the important non-pharmacological habits that need to be a part of the weight management process. So we understand that many of the drugs, the GLP-1 drugs, are going for long-term usage. And we recognize that that's probably what we're going to see the conversation being talked about. But when it comes to a plan design conversation, I think that it's best to put a protection in place for a limited use of the medications and coverage. The other conversation that's sort of important to have here as well is that individuals generally, when they have a skin in the game, tend to be more effective at producing outcomes in anything that they're a part of. And we saw a lot of that research really elevated through some of the value-based design conversations 10 to 15 years ago, when we took all costs access to the medication off we found that people who had a $15 to $20 sort of skin in the game versus a $0 copay skin in the game actually made people tend to be a little bit more engaged in the behavior of adhering to the medications or the regimens. So obviously up for controversy regarding the time frame for approval, and also the sort of the importance of putting a lever in place that allows members to have access to the drug, but also protect the plan. You know, we're talking about lots of opportunity for utilization, both in the diabetes arena and if you open up an obesity sort of coverage conversation. But if you can put some levers in place, like we've suggested here on this slide, it begins to help increase the opportunity for the right person to get the right medications and be managed in the right way. Austin, do you want to flip the slide really quick for me? Thank you. You know, we haven't talked, we talked a little bit about cost. And I think when you talk about cost share, I think it's important to understand sort of the differences in the cost sharing as it relates to these types of categorical medications. So in this slide here, we can see some of the older drugs, and obviously cost wasn't a conversation when you talk about the use of drugs like phentermine. You know, we're talking about a monthly cost of about $25. The challenge with these older medications wasn't really a cost conversation, but more about like, it has a lot of side effects, causes a lot of challenges. And we're also concerned with that these can't be used in every single individual. Obviously, when you flip the slide to the GLP-1 conversation, we're talking about it being upwards of $13,000 to $15,000 a year for somebody if you're covering these medications. If a person out of pocket has a little bit of cost share, but it isn't just 100% paying, you have to kind of consider the cost share, that it's enough to get the member to want to have the skin in the game, but also not lose the opportunity to not have access to the drug if you choose to cover these types of medications for obesity on your plan design. One of the things that we've seen in our experience with plan sponsors who are offering weight management with prior authorization, ensuring that also while they have that drug covered on the plan, that they're also working with a health coach, is that if the cost share is more than a couple of $100s, tends to be putting up barriers to people's access to those medications. We obviously aren't taking into play here a lot of conversation around what the manufacturers are putting into this and how much they're owning in terms of putting these copay savings cards out into the marketplace. But we're just purely talking about if those things weren't available, how would people access the drug on your plan design? I think we'll flip to the next slide. We're getting lots of great questions. So in summary, obviously, you know, we know that we're talking about a population for obesity that is significant. 42 to 50% of individuals in the United States would be eligible for these types of medications based on the diagnosis of obesity. We also know, obviously, that diabetes is a growing category for many of our plan sponsors as well. That the cost of these medications is causing more and more self-insured employers to think about how to continue to be able to sustain coverage of these important medications for people who were trying to save long-term cost around their medical utilization. Obviously, we know that if we can improve someone's blood sugar or decrease someone's obesity or decrease weight, we know that we can improve and decrease access to long-term high-cost utilization channels such as dialysis, such as hospitalization. So there's a value in putting sort of a tool in place to have people who are eligible for this to hopefully improve the cost long-term. It's the conversation of how to put the barrier in place now so that people are not wild west with these medications. You know, I think outside of just plan design coverage, there are some barriers to the use of these medications that some people will not like. Obviously, the use of injections. We will see, I'm guessing, Austin, I'll ask you this question. You know, we are suspecting in the pipeline here soon some oral medications in this category. Do you suspect to see similar sort of conversations around these drugs for obesity if we see the GLP-1 oral medications coming out, or do you have any insight into any of that?
Yeah, so there is one GLP-1 actually orally available for diabetes already. It's, again, same active ingredient as Ozempic and Wegovy. It's semaglutide under the brand name Rybelsus, and it's been on the market for a couple of years now. And yeah, there are a lot of challenges with that in terms of how the drugs are absorbed. There's a reason why all of them are injectable, but as the technology progresses, obviously, if we can offer daily or even less frequent than daily oral meds, many people are going to be much more willing to do that than giving a self-injection. And I believe there's multiple drugs in the pipeline already that are being investigated for that to see if we can get similar benefits to the injectables.
Yeah, so I think that makes it even more critical at this point in time to consider how you want to handle as a plan sponsor your access to these types of medications. As we start to see sort of even the routes of administration become easier and the proliferation of the different types of medications, it's important to consider as a plan sponsor how you want to approach the philosophy of treatment of obesity and even access to these medications as it relates to individuals who have diabetes. So we're getting some questions regarding recommendations on how to handle floods of inquiries, cost concerns, and prior authorizations to these medications. Hopefully we've seen some of that conversation happen so far. I think it's critical and important that when you have a benefit plan conversation, that you're thinking about how you want to approach the access to these medications. We obviously highly recommend a high touch nutritional and lifestyle conversation going alongside the access to these medications. We know that we're seeing a lot of direct consumer ads, particularly talking about access to these medications through many of our mainstream media, large corporations who have been in the weight management business for years, that have lots of very recognizable brand labeling. We are seeing people who are getting access to Mounjaro directly through companies like Weight Watchers and the recent buy-up of a telehealth company for them. So, people are going to start accessing things potentially off of the plan anyway, but it's important that if you have these medications on your formulary, that you think about how to ensure that you're protecting the plan by ensuring the right meds get to the right person. I'm getting a question regarding what if a person doesn't have diabetes but needs to lose weight prior to a joint implant? Austin, do you want to just kind of handle that conversation? Just a little bit of your thoughts about that. I've actually seen this personally, and I'm sure you're potentially hearing these conversations as well.
Yeah, it's a really good question. There are multiple medical situations where someone may be required to lose weight before they can do something that's medically necessary. Joint replacements are pretty common there. Normally, there's going to be a lot of structure provided, from my experience, through that orthopedic clinic, in referrals to physical therapy and lifestyle coaching, and a lot of direction given to the patient. These medications do take some time to work, but they can work relatively quickly as long as they fall under those approval criteria, right? If this person needs to lose weight before they can do a joint replacement, then they certainly are going to qualify as a BMI over 30. We're not talking about someone with a BMI of 26 who needs to lose weight for a joint replacement. So I think there could be clinical utility there. Obviously, when we are talking about duration of use in that case, it probably doesn't make a ton of sense to go into that thinking that this person needs to use the med long term, if it's really to try to help get to where they can become more mobile, hopefully get to moving around more from a lifestyle change perspective anyways, and then be able to maintain that weight loss after the surgery is done.
Yeah, so kind of secondary to that, Austin, there's some comment/question. You obviously talked a little bit about it, but per Novo Nordisk, Wegovy is supposed to be a forever drug to manage the chronic condition of obesity. How is this reconciled with the time limits and behavior change focus? So can you talk a little bit about your thoughts on sort of what we're seeing in terms of coming from the manufacturers regarding long-term use? There's some protective cardio elements to those medications, particularly in certain disease states. But can you talk a little bit about how you can sort of reconcile maybe that this doesn't necessarily need to be a long time medication. And then anecdotally, have you had any experience with anybody working off of the medications as a part of their plan?
Yeah, that's a probably multi-billion-dollar question right there that you're asking, and that's we could spend a lot of time off of a webinar talking about the marketing of this and some of the mechanisms around that and the perception of overweight and obesity. I think the way that I go about reconciling and coaching patients and educating them and counseling them about this on a pretty regular basis when I get asked on it is, these medications assist in overcoming some of those initial barriers, right? The mechanism by which they're helping people lose weight is they suppress the appetite via feedback loops from the GI tract. They help your gut feel full more quickly and longer, so you don't want to eat as much, or you feel side effects if you do overeat. So it creates kind of a negative reinforcement. So it helps kind of instill some of those things initially. But in order to sustain this long term, like, we've got to make some lifestyle changes. So it's going to help along those sides. But continuing to try to, if that person in my practice setting has access to our Choose to Lose program, making sure that they're getting plugged in with our health coaching opportunities. If we don't have that ability to offer them that particular program here, making sure that they're either leveraging other opportunities that are available through their benefits, or talking to them about stuff that's direct to consumer, or just counseling on the basics of, what do you like to do for exercise? What's your current diet like? And providing some of that one-off coaching. It is challenging. I don't know that there's a perfect answer to that question. Our pharmacy resident was at the National Pharmacy Conference, and there was a similar discussion being had regarding the role of these medications. And he actually asked the national presenters that question, and they didn't have a great answer for him either, because I think that it's very gray, if I'm being honest with you. But when it comes to a population health and a cost perspective, we've got to target some of the underlying issues that are contributing to obesity up front. We can draw a lot of parallels to managing this situation, like a lot of other health conditions in the mental health space and some of the other metabolic condition space on, food choices and activity levels and some of the things baked into our society. So, my approach anecdotally, Jessica, is, coaching patients on those lifestyle changes, describing the importance of making those changes in order to receive the long-term benefits in case they can't access the medications long-term, like we see with the shortages, or if it's no longer affordable, or if they have side effects and have to stop it, how do they continue to see the benefits initially?
Yeah, I think you highlighted there one of the questions that we had, which is the differentiation of sort of what TRIA does from other weight loss solutions on the market. So obviously, the approach of using the pharmacist who's an expert in the medications. The other sort of component to this is we're forgetting these people aren't just on these medications, they're on multiple medications. So we're talking about a balance of ensuring that you're not only getting the coaching from the nutritional and behavioral aspect, but also the coaching from the pharmacist to long-term to tolerate the medications, to make sure the medications are not a long-term solution. But you're right, we don't know yet what we don't know, and time will give us more answers with that in terms of how long these medications are going to be utilized, and what we will see in terms of tolerability long-term. And then obviously, I think for most clinicians and healthcare people, long-term medication use is not usually what we like to see for people. We like to see sort of global changes that allow them to not have to be on medications to control their symptoms or disease. Well, we're running a little bit out of time. We have a bunch of questions. The last question I will take is regards to getting some questions about PBMs allowing the manipulation of the PA, and some PBMs, allowing limitation on off period and ensuring member copay. And I will give you the caveat, and most of you know this who are on this call. Whether or not a plan sponsor has the ability to influence the PA criteria is really dependent upon the PBM, the potentially the broker involved, and potentially the potential buying power of that individual as well. I just would encourage the conversations to continue to be had by plan sponsors about how to best protect their plan in a way that ensures that they can sustain a healthcare benefit plan long-term, because this could potentially be a challenge for many people financially. So, Austin, do you have any final conversations? I think we have several more questions, so we'll make sure and respond. The last one I got was regarding possibility of using meds like Wegovy and Ozempic for alcohol avoidance. I haven't seen that. Have you seen that, Austin?
That's interesting. I've not seen that. There's just an article published in the last month or two about using a much cheaper drug called naloxone that also is in a combo product for overweight and obesity in men who have binge drinking history with effectiveness there. But I've not seen this particular class ever used for that before.
Well, one of the things that I want to assure you is that if any of you have further questions regarding this, what I'm most proud sometimes about my clinical team is they are on top of these types of things and they're looking at the literature on a regular basis. So if you continue to have questions regarding the use of these medications, do not hesitate to contact someone at our team, the sales@triahealth.com. If you have questions about the way in which we run our program regarding weight management, or any questions regarding just the pharmacy advocacy program in general, please feel free to reach out to us, and we will get you the answers and the resources that we can help you with so that you can best protect your plan and also ensure that your members are getting healthier. We want to thank you all for being with us today. We will send this slide deck out to all registrants, and we hope that you all have a great rest of the day and continue to have conversations regarding these exciting topics.